Moving out of the trauma, I'm going to talk to you a little bit now about juvenile flatfoot reconstruction. And been doing this for quite a while, and I've kind of come to what works for me, and which is not necessarily the dead-on answer, but come up with some things and some protocols that work pretty well for managing a lot of this juvenile flatfoot. The presentation for the majority of these patients, for me, is typically due to parental concerns. And, I get some referrals from the pediatricians when the parents complain, for the second or third time about their kid with the flat feet. But generally speaking, what I've found is that unless if the kids are having pain, it's pretty legitimate. They're not usually going to complain about pain. They're going to avoid activities, they're going to do other things, the parents are going to notice things, but unless it's pretty bad, the kids don't usually typically complain. They will instead migrate towards more sedentary habits, and this has gotten a little more complicated in our digital society today with the video games and with social media and things that I think in general, we're seeing that the kids are somewhat less active. Now, certainly with in our area at least, all the soccer leagues in Metro Atlanta and all the other organized sports, it does kind of offset that. So you do see some of it, but again, they'll tend to be more sedentary. So the question becomes is what really constitutes a juvenile flatfoot? And what age are we talking about? And this is kind of a new twist for me to look at this a little differently because I am treating more people that are a little bit older more as if they're juvenile flatfoot, if their BMI is low enough, and if if they've got good tissue and all, we may be able to push this more into the adult population. And so that's why I asked the final question there of, is this only for peds? And I think the answer is not necessarily. I don't think we can push this blanket across the board and do these procedures on just any adult who's got a higher BMI and other issues. But I think there is a subset of the adult population where we can treat them as if they are more of a juvenile flatfoot type entity. When we evaluate these patients, certainly we're looking at history. I always ask about the family history. I love getting these kids in, and the mom will tell me, yeah, their dad's got horrible feet. He comes home and complains about his feet every day. And that certainly makes it a whole lot easier because talking to a parent for me about doing something invasive on their kid when they've just met me is a little bit of a stretch, but I'm able to explain to them that in podiatry we have the unique ability, since we see people from 6 months up to 106 years, that we get to see the timeline of how these deformities progress with age. We do our exam, we look at the age of the patient, plain film x-rays, and in some cases we need the consideration for specialized imaging if we think there might be something else going on, and we'll look at that. Standard clinical evaluation, we want to look at the ankle range of motion, and I think this is something we just can't stress enough. We have to be looking for and sensitive to that equinus contracture, and realize that if you are not reducing the foot, of course, you're going to get a false negative, and you're going to get a lot of that midfoot motion showing up as ankle motion. So you really need to be diligent about performing a very strict silver scoil test and looking for that underlying equinus contracture. Look at the mobility of the subtalar and mid-tarsal joint. Look at the forefoot to rear foot relationship. Actually have the patient stand up. I know we're busy, but you have to do it. And then performing the Hoopscher maneuver. And I actually do this with neutral position x-rays on a lot of these patients. If for no other reason, I think it serves as a wonderful educational tool in talking to the parents. And we're able to show them where their kid's foot is now and where it should be neutral position wise. Silver skull test, let's go ahead and tap that and make it run, please. This patient on the operating room table, obviously, that I was taken in, and you load this foot with the hind foot in neutral, and you see the foot wants to escape into that valgus position to help compensate. But even with the knee flexed 90 degrees, you can see this is negative 25, 30 degrees. So this is a true gastrocoelial equinus in this particular instance. So you know that this is not a gastroc recession, but this one's a TAL. You need to address the conjoint tendon in this particular instance. Let's go ahead and advance to the next slide. There we go. So categories for juvenile flat foot, I just break it down into flexible and rigid, and I think we all know what this really constitutes. But the outcomes are different, and the treatment requirements are certainly different as well. Our initial evaluation, clinical exam, then I'll get a full set of x-rays. I'm looking for mid-tarsal subluxation, looking for the talar first metatarsal alignment, looking for any accessory ossicles that may be compromising the insertion of the posterior tibial tendon. Is it far enough gone that there's navicular cuneiform fault? Is there a calcaneal inclination angle? Is it compromised? How much metatarsal stacking is there? Is there any suggestion of a calcaneal navicular bar? Is there a halo sign, TN beaking, obliteration of the anterior and middle facets? All things that would be consistent with tarsal coalition. And again, we'll see that. So when you look at your plain film x-rays, here's this kid came in about age 12, 13, as you can see, based on the growth plates closing, distal tibial growth plates closing. But you can see this basically 0 degree calcaneal inclination angle. You see this significant uncovering of the talar head. You've got probably a 45 degree deviation off the talar first metatarsal axis. And so we can see what's going on here. And you can see the effect that more likely than not, as Luke pointed out yesterday, that with the calcaneal inclination angle, there probably is a significant equinus contracture here that's going to have to be addressed as well. So just kind of all the things that we can take away from all the clues that we have here on the plain film x-ray. We have almost 100% overlapping. You don't see the stacking of the metatarsals, so you see how much pronation through the midfoot and forefoot that there is, and you're picking that up on plain film x-ray. Neutral position x-rays, what we're shooting to do is to restore the first metatarsal talar axis and look to see if we can visualize the subtalar joint. Because in a maximally pronated foot, the lateral talar process has moved anteriorly, that screwing mechanism of the subtalar joint, and it's blocking the x-ray beam. But when you put them back in neutral position, you find out, A, is there coalition, and B, can you reduce them to neutral position? So here's one that you can see, significant uncovering of the talar head here. You can see that the stacking here, and you don't get a real clear view of the anterior and middle facets, the subtalar joint here. You can kind of see the posterior facet, but when you look at the deviation here, you see the loss of alignment of the talar first metatarsal axis. You see this naviculo-cuneiform breach. Well, let's go ahead and do neutral position, and now we've restored the alignment. You've got 100% coverage of the talar head with the navicula, and when you look at it on the lateral view, now lo and behold, and not only have you restored the alignment here, you can sort of see the posterior facet here. Now you can see the posterior, anterior, and middle facets, and you know that this deformity is completely flexibly reducible. Specialized studies, CT, MRI, certainly dealer's choice. If I really suspect it's an osseous coalition, I'll get the CT. You can get finer cuts. If you're not sure and you think it might be more fibrous, the MRI certainly can show you the fibrous coalition. It can also show you if any bone marrow edema at the adjacent interface of calcaneonavicular bars and of subtalar coalitions in like as well. Treatment options, certainly conservatively, custom molded orthotics are certainly still a wonderful, viable alternative. And then certainly looking at surgical intervention for those that can't be managed with orthotics or cannot tolerate orthotics. And I think that might be the more key indicator. For me, I look at it, and we'll touch on this more in just a second, but if there's a significant underlying equinus contracture, and a lot of times they may have tried an off-the-shelf device first, and if they're having more pain with the off-the-shelf device, then that's a key indicator for me that probably this patient's going to require surgical intervention at some point. That if they're pronating so severely due to the underlying equinus into an off-the-shelf device and cannot tolerate an off-the-shelf device, then I'm not wasting the time, the effort, the resources, the money in sticking it into a custom molded orthotic that they're also not going to tolerate either. Prognostic indicators, therefore, are the equinus and if it's a rigid contracture. These are the two biggest indicators that I have that somebody is going to go down more the pathway of surgical intervention. Procedures, this is kind of my laundry list, and this is kind of the direction that we go. If there's an underlying equinus contracture, first and foremost, whether you're doing an adult or a pediatric or a juvenile flatfoot, I think if you don't address the underlying equinus, your procedures are doomed to failure. I then use the building blocks, kind of moving down the list here. That for me, the Evans calcaneal osteotomy is my major building block that I build everything else on. And then if we need to address the medial column with Kidner, medial arch reconstruction, cotton osteotomy, navicular cuneiform fusion, and if they've got an associated juvenile hallux valgus deformity, closing base wedge osteotomy as well. So I'm going to walk you through this. This is, Tom Smith, one of our former faculty members who passed away a number of years ago. He was an absolute artist at teaching this, and so I'd like to credit him with what he taught us about this. There really are about 4 different planes to the dissection when you do an Evans calcaneal osteotomy. And though I'm not as artistic as a lot of our faculty members, I do try to draw out the anatomy, showing where we're going, and we're able to see where the CC joint is and lay that incision line in almost into the relaxed skin tension lines here obliquely, which allows us to get in. It gives you a beautiful scar and gives you access to everything that you need. So we've made the initial skin incision in the relaxed skin tension lines obliquely here. We're going to then get in and undermine along the deep fascial plane, and then our next dissection plane going through the deep fascia to elevate the EDB up. And again, I want to stress here that this is minimal dissection. You do not want to over dissect this, because if you over dissect this and you release the ligaments across the calcaneal cuboid joint, you will allow your anterior calcaneus to displace, and you'll end up with an unstable graft and an unstable situation that you then have to fixate, which is really not necessary. So the next step, we know that the first plane was here, and then 90 degrees to that is the deep fascial dissection here. We're going to make our incision staying superior to the border of the perineals, keeping them in their sheath, and then elevating the EDB belly straight on up. Again, retracting it, we've now got the anterior lateral calcaneus exposed. It's a pretty easy approach. The only things you have to worry about, you've got the intermediate dorsocutaneous nerve branch up here. Sometimes you get a crossing branch from the sural nerve across here, and keeping the perineal tendons protected in their sheath makes your life a lot easier. Now you've got direct access. You can check and see and confirm where the joint is before you start to make your cut. I usually will go ahead and place a 25 gauge needle at the level of the location of where I think I want my cut to be to confirm it, because there's nothing worse than being either too close to the joint or too far proximal. If it's too close to the joint, you fracture into the joint. If you're too far proximal, it gets to be very difficult to distract this. So there's your C-arm picture. You can see the needle right here, and you can see that that's probably a little bit closer than I want to be. But you ideally want to be probably 8 to 10 millimeters proximal to the joint, so that you've got good bone to get into, and you've got room for your distraction to make this easy to accomplish. For me, who's a solo practice, when you don't have a lot of help, you want to use all the tools at your disposal. So we've confirmed our placement. We'll then go ahead and make the cut. You can see I use a distractor on here. And these are beefier pins. I don't like these little distractors with a dinky pin. These are 3/32 inch Steinman pins. It gives you some pretty robust distraction. You dial this out, and the beautiful thing is not only can you dial it out to get the graft in, it holds it, and you can look at it radiographically and assess your correction before you cut your graft, before you start trying to pound your graft into place, and you're not fighting with the compression across this area from the perineals and from the ligamentous structures. So here it is. We've got it distracted out. and I'm now checking. I've got pretty close to 100% coverage of the talar head, and I've got a pretty straight lateral border to the foot now that we've distracted this open. I'll go ahead and measure for my graft. I just take the disposable ruler, I cut it off, I measure depth, height, and breadth of the graft, and then I still cut these things. It's so easy to do. It's way cheaper than if you want to use the prefab grafts, fine. But I find this takes me about 1.5 minutes, 2 minutes to cut the graft and have exactly what I want. And if you're using, whether you're using iliac crest or fresh frozen femoral head, you've got some extra if the graft collapses or if the graft's not of great quality and you need to recut it. You've usually got plenty to go with at a half or a third the cost of what the pre-cut grafts are. Here you can see I'm press fitting the graft, and I'll open up the distraction a little bit more so that we're not pounding on this graft too much. Sometimes the quality of these grafts, as you know, if you do these things, are not great, and you start trying to tap them into place, the cortex starts to break, and you end up with a situation that's not what you want. But here it is press fit. You want to check to make sure the cortex laterally and dorsally are not proud or not going to cause problems. And then once you've done that, you can take your distractor off, confirm your correction, your coverage of your talar head, and you can see that the cortex of the graft here is sitting pretty flush with the lateral calcaneus here as well, and then check to make sure it's not proud sitting up above on the lateral view either. So tips, the planes of dissection, you're in the oblique skin lines for the skin incision. You're parallel to the perineals, but above it for the deep fascial. And then your bone incision or your bone cut is actually parallel to the joint, perpendicular to the weight-bearing surface as you make this. So you've really got 3 distinct separate planes of your dissection. You want to limit that dissection. Do not over-dissect the top of the calcaneocuboid joint, or you will end up with a problem with disruption, either your graft popping up or your anterior calcaneal section popping up, and it really is an unfortunate thing. It's easy to fix, especially if you catch it in the OR, but the main thing is just don't over-dissect the top of the joint and go too far distal, and you won't have to deal with this. Distraction is key. Really get it open, and then you can press fit your graft in. Fixation generally is not necessary unless you've over-dissected it, or if concomitantly you're doing the resection of a calcaneonavicular bar, and at that point I will put a wire in them. So the Evans effectively lengthens the lateral column. It pushes the forefoot medially. It relatively shortens or tightens the perineus longus, because as you're lengthening that, you're tightening that up and you're pulling the first ray down, which again augments your repair. It tightens the plantar ligaments and fascia by increasing the bone length, or the internal cubic content, as Mac used to say. Take you through a couple of cases. 17-year-old gymnast, she came in, she had a history of painful flat foot, painful with tumbling and all. Left foot was significantly worse than the right, but it was significantly flexibly reducible. You can see the significant uncovering of the talar head. You can see as we talk about this increased calcaneocuboid abduction angle, and here she is long-term follow-up. In this one, the graft quality that we were using that day was not good, so I did put a threaded Steinman pin into it to hold the graft and to keep it from being able to crush and collapse that graft. And this is several years out. She came back for me to see about something else. You can see that you got nice, beautiful visualization of the subtalar joint, which is in neutral position. The lateral talar process directly under the line of the tibia, good calcaneal inclination angle, and good alignment of the talar first metatarsal axis postoperatively. This gentleman came in, I actually did his surgery a good number of years ago. He had a long-standing history of flat foot with hallux valgus deformity. He had a monstrous accessory navicular. And I actually had taken pictures of him back then, and this is about as pes pancakeus as I get to see anyway. I mean, he left a duck footprint when he would walk across the floor. And the interesting thing that he told me was he wished he had gone ahead and had me do his other foot. He since has bought a cabinet shop and is on his feet all day and doesn't have time to do it. But again, you can see the talar axis here, far from alignment. the uncovering of the talar head, which you don't even really get the full appreciation of because of how large the accessory navicula is. And 9 years post-op, I had done Lapidus, Kidner, Evans, and I had done his second toe. And that's the only thing he complains about is his second toe being stiff. He's super happy with the foot otherwise. And you can see the anchor in the navicula from transfer. The last case I'm going to take you through, 18-year-old female. She came into me. She had pain with weight bearing. She had a moderate flat foot, but it wasn't really horrendous. She had 0 degrees ankle joint dorsiflexion, and clinically, to me, she had a restricted subtalar joint. Unfortunately, she had been to Children's Hospital of Atlanta. She had been treated for an ankle sprain, supposedly, had been through 2 rounds of physical therapy, fracture boot immobilization, a little over 2 years of treatment, thousands of dollars of non-covered treatment. And she came in, and I looked at her and I said, you know, I don't really think you have an ankle sprain issue. They had done an MRI. The MRI was interpreted as being normal. I got the images, and guess what? It wasn't normal. I looked at the images myself. This is what her foot looked like, and you can see that you just don't see clear visualization of the subtalar joint. You can see kind of a sclerotic appearance of the sustentaculum there. And against her wishes, to help prove this, I went ahead and injected her subtalar joint with local anesthetic. All of her pain went away. Ultimately, went ahead, did a subtalar fusion on her. She has done absolutely beautifully. I've got one of the most glowing reviews on my Google page is from her mother, after they had spent thousands and thousands of dollars at Children's Healthcare and never had a proper diagnosis. We did a subtalar fusion on her as well as a gastric recession, and she went on to work as a barista as her way through college, and now has a job where she's on her feet, most of the time, and really with no pain. So, successful outcome with a good diagnosis and choice of appropriate procedures. So, take-home points for this: what are my workhorses for management of the juvenile flatfoot or juvenile flatfoot-ish type deformity? Number one, probably is the gastric recession more often than the TAL. The Evans calcaneal osteotomy, which is my main building block. And then if there's still instability in the medial column, or if there's an accessory ossicle advancing the posterior tibial tendon, modified Young's Teno suspension, which takes away a lot of that floppiness in the medial arch. And if you've still got some adaptive supinatus in the medial column, proceeding on with a cotton can be a nice round out to the procedures to help give you that stable correction. Thank you very much.